Hello from Austria. My name is Florian Dirisamer. Apologize for not being with you, but Lufthansa has cancelled my flight back to Austria, so I cannot be with you. But I want to share with you some ideas about the importance of osteotomies for torsional abnormalities in patellar instability. We all know that missing important risk factors means bad outcome and eventually redislocations in patellar instability surgery. So this is something that's very important. We cannot be successful doing an MPFL in every case. We have to identify what's going on in this case. And for the patellofemoral joint, we know that there is a strong interaction between stability and alignment. And we have to address this if we have the impression in our workup that this is relevant. So we should address those bony fractures by adding osteotomies, and eventually this will end up even in an unloading procedure for the cartilage surface. So this foundation is something that's very important, and strong foundation will be a good investment for our plant of stability to grow. And of course, this means eventually more surgery and eventually causing more trouble. But in the end, when we do this correct and build this strong foundation, we will be successful. You all know these instability factors for the patellofemoral joint, and what's interesting in our case is the static factors, and there is somehow clear that valgus plays an important role, but to be honest, there is no evidence for varus osteotomies in patellar instability. We all know that they are clinical very effective, but in terms of literature there is not too much knowledge about it, and there is at least low evidence that derotation osteotomies in more than 20 or maybe more than 25 degrees of anteversion are important. And this image shows this very well. The only difference between the left and right picture are 15 degrees of internal femoral rotation. So what happens is that the whole extensor apparatus is lateralized and the patella is subluxed. So this is clearly an instability factor. To explain this a little bit easier and not from a biomechanical point of view, when you imagine a train jumping off the track, you put the train back on the track and everything will be fine. But when on the same spot the train pops off the train again and again, you will eventually know that there is a problem with the track. So bringing the track under the train, namely the trochlea under the patella, may be a good idea in those cases. And that this is clinically effective was also clinically shown, for instance, by Manfred Nilitz's group from Germany. He did a case series with increased anteversion of about 34 degrees in this group, and all those clinical parameters improved post-operatively. To show you a case, this is a case of a chronic bilateral patellar dislocation since early childhood. The patient had 2 previous surgeries, one a very brave attempt with a lateral release, and then they had an electrogius done bilaterally. She had a valgus angle of 9 degrees on the right-hand side, 8 degrees on the left. Both knees had dysplastic trochlear situation, and a pathologic anteversion of 30 degrees versus 32 degrees on the left-hand side. Something like a TTDG was measured. I don't know exactly how this was done in a trochlear dysplastic case, but there is something to do with the tuberosity as well. And of course, this patient already had some amount of patellofemoral osteoarthritis. What we did was a distal femoral osteotomy with a varisation and derotation in a biplanar fashion. We added a tibial tuberosity osteotomy and an MPFL reconstruction. This was done bilaterally within half a year. The follow-up is meanwhile more than 9 years, and I know that this patient is still perfectly stable in both knees. but has sometimes only mild anterior knee pain due to the patellar arthritis. So this is somehow surprising, as we planned this procedure more or less as a preparation for a knee arthroplasty later on, but normalizing the biomechanics, normalizing pressure in the knee joint seems to work quite well. So to sum it all up, osteotomies play an important role in the treatment of patellar instability. The role of these osteotomies is clinically very clear and effective, but there is still low evidence, but growing evidence in this field. We have still problems with the reference values that are still under discussion. The measurement techniques are important, so do this always yourself. In terms of the level of osteotomy, I prefer to do it on the knee, but you can do it on the hip side as well. Tibial osteotomies are very rare in my hands, but you should consider them when your femoral derotation ends up with in-toeing. Thanks for your attention, and enjoy Lyon as I would have done being with you. Thanks.